Okay, we are officially recording. This is an NUR 188 Zoom session specifically related to Unit 4 exam and prep. Just wanted to provide this opportunity for you guys to ask some questions, kind of clarify a little bit of content. Thank you all for doing your clinical assignments this week. While I did not look at everyone's paperwork, the entire assignments, I did actually go through and read everyone's journal because I wanted to get your thoughts on, how you're coping with all of this and, how you see the class going and your progress towards meeting course outcomes and clinical behaviors. And I appreciate the honesty. I appreciate people sharing, how they were feeling and suggestions for improvement. And one of the things that came out was definitely more Zoom sessions. You like the face-to-face stuff. And as well as, some anxiety about today's exam. So that's why I wanted to offer this session today. So we're going to jump right into it. I am recording this session. It will be posted up there. But I'm just going to kind of start at the top and work our way down, looking at the questions that you're submitting through the chat box and just talk that through. And then, of course, if any questions related to content, the exam, I'll entertain other questions too, but the main focus of this is really the exam. So first one that's up is describe HHNKS, looking at treatment, diagnosis, and signs and symptoms. Well, the cool thing about HHNKS, if you could say it's cool, it's not really a good thing, but it is very similar to diabetic ketoacidosis. The big difference is with HHNKS, we typically see this in type 2 diabetics, and you don't have the ketoacidosis piece. They might get into a metabolic acidosis, but they're not necessarily going into fat metabolism and breaking down ketones, simply because there is still some insulin being produced from the pancreas. Okay, so you don't have the severe metabolic acidosis. You're likely going to have a low-level metabolic acidosis, but it's not going to be as severe as what you would see in a DKA. Now, in relation to treatment, that actually is not any different than DKA. HHNKS and DKA are treated very similarly. In both cases, the patients are severely dehydrated, so volume replacement is going to be really important. And we always do initial volume replacement, fluid resuscitation with isotonic fluids. So typically it's going to be normal saline or lactated ringers. And the reason we're doing that is when we put that fluid replacement in there, remember that this patient is severely dehydrated. So when we put fluid in there into the veins through the IVs, we want it to stay inside the vessels. We want to support circulating volume. Okay, so if we're using a hyper or a hypotonic fluid, you're going to start causing fluid shifting. So our initial focus is to support that circulating volume, which is why we use isotonic fluids. Once we get that replacement in, and that replacement can be several liters. Severe cases of DKA, I mean, we dumped probably 10 liters in a patient first before, just to support the circulating volume before we've switched over. It really depends on the individual patient. But once we've replaced and supported that circulating volume, we do need to switch over to a hypotonic fluid. And this is where you typically see the half normal saline. Because the other piece that happens when somebody's severely dehydrated, there's not enough fluid inside the vessels, is the body, in addition to making you thirsty, will try to pull some fluid from the cells. So first things first, we got to support circulating volume. But then as we start replacing it with the hypotonic fluid, some of that fluid, that water, is going to move back into the cells, which is going to be much better for the cells for functioning. Okay. So hydration is going to be key with your DKA and HHNKS. The other big thing we need to deal with is getting that glucose level down. And for DKA, basically stopping fat metabolism and getting those cells to be able to use glucose again. And insulin does that by helping the glucose move into the cells so the cells can use that glucose for energy instead of burning fat. So, a couple big things with that. It's really about hydration. It's about getting the IV insulin started. As you do those two things, the metabolic acidosis should begin to correct itself. Those of you who were doing the med-surg cases this week, there was a question about sodium bicarbonate on there for Jonah Hill. And the reality is, in today's practice, we don't use sodium bicarbonate as much as we used to, just simply because by giving the fluids, by giving the IV insulin, we are stopping the cause of the metabolic acidosis. We're starting to reverse it. So, and we want to have a gradual change. We don't necessarily want to have a rapid change, because then you have fluid shifting and that can cause more damage to your patient. So we're not typically using sodium bicarbonate as much anymore unless this metabolic acidosis is very severe. And I'm talking like a pH of 7 or below 7. Okay, so I think I addressed that one. Okay, next question. Why is the slowing of carb uptake important? And this is in regards to the MOA of the alpha glucosidase inhibitors. So the whole idea of treating diabetes, particularly in this case, we're talking type 2 diabetes, because now we're looking at the oral anti-diabetics and the non-insulin injectables. So by slowing carbohydrate digestion and absorption, what we're looking to do is slowly raise the glucose level. We don't want to wrap it up and then down. So that particular classification of meds, it's all about slowing down the digestion and the absorption. They're still going to get the same level of glucose, the amount of glucose that they would have gotten regardless, but we want to do it on a much slower pace. We don't want a rapid peak and then drop. So it's not uncommon for you to see patients, type 2 diabetics, on multiple oral anti-diabetic meds to help manage their diabetes. Okay, next question. For complications of peptic ulcers, hemorrhage and obstruction both have hypovolemic shock symptoms. Will there be other specific symptoms that will tell you to decide between the two? Okay, great question. The reality of this is, at that point when they're having a complication, you have to respond to the patient condition. So hemorrhage, obviously they're losing blood, they're hypovolemic, they're not going to have enough circulating volume. You know, with losing the blood cells, we're not going to be circulating as much oxygen simply because we don't have the RBCs and the hemoglobin to do that. With obstruction, they essentially are going to be vomiting, nothing's moving through. So you do get a fluid and electrolyte imbalance. At that point, regardless of whether you're talking about hemorrhage or obstruction, our purpose, our main focus is going to be supporting patient life. So looking at airway, breathing, circulation. So first of all, circulation, because you're looking at a hypovolemic situation, regardless of which one we're dealing with. So it's going to be supporting circulating volume with your isotonic fluids. Certainly we want to maximize oxygenation. So sticking some supplemental oxygen on these patients is going to be a good thing. If it's hemorrhage, depending on where we're talking about, if you're talking about a stomach ulcer, or even the first part of the duodenum, a peptic ulcer, you have to understand that blood in the GI system acts as a cathartic. So it's coming out one way or the other. So if it's actually in the stomach, this patient will likely start to vomit blood. So whether it's bright red blood or coffee ground emesis, you're still going to see the presence of blood there. When we think about lower GI bleeds, again, blood is not supposed to be in there. It acts as a cathartic, so it will stimulate peristalsis, and that's when you have somebody with a lower GI bleed where they're passing stools with blood. But again, regardless of whether you're talking a hemorrhage, a perforation, an obstruction, they're all going to present with a circulating volume problem, a hypovolemic problem. So our focus is going to be supporting circulation. Okay, let me work my way down the questions here. So if conscious during hypoglycemia, what would be the priority administration and why? There's a couple questions here. So let's start with that one. So if you have somebody that is conscious, well, let's kind of back up a minute. They're showing signs and symptoms that would be indicative of hypoglycemia, okay? First things first, if I have the ability to test their blood sugar, I want to do that. you know, in a hospital setting, I have access to the glucometer. We can test that blood sugar. We can do that assessment piece. We can see what's going on. If I'm out at the grocery store, and this actually happened to me, I think I included it in the capture, where I was out in the grocery store and one of my mother-in-law's friends was there and I knew she was diabetic. You know, we were having a conversation and all of a sudden, like, she literally, like, I don't feel well, and passed out. Now, didn't have a glucometer there, couldn't check her blood sugar, knew that she was diabetic. Again, if this is a hypoglycemic episode, that's going to be more deadly or more immediately deadly than a hyperglycemic episode. So in that case, literally what we did is we grabbed some cake icing, stuck it underneath her tongue. Obviously somebody called the EMS. By the time they got there, she was actually up and awake and talking. So hers was a hypoglycemic episode. But back to the question, if they're conscious, or even if they're not conscious and you're suspecting hypoglycemia, if you have the ability, the first thing we want to do is check that blood sugar. If we don't have that ability, like I said, you know, we were in the Wise Market, you're going to treat it based upon hypoglycemia. Because the reality is, even if you raise up their blood sugar, that generally is not going to be immediately deadly to your patient. So that's what you would do first. If you have the ability to test, let's do that. If you don't, then you're going to treat it as if it's hypoglycemia. Next question, what does tight glucose control mean? So when we use that term tight glucose control, we're really looking at overall control of a patient's glucose, of their diabetes. Is their diabetes well controlled? And remember the tests we look for that will tell us if their diabetes is under control. That's the hemoglobin A1C. And for diabetic patients, we want that below 7%. Below 7%, we consider their diabetes well controlled. If it's above 7%, it's not. So when we use the term tight control, we really want to keep their glucose, you know, below 7%, the A1C, and their fasting glucose and their postprandial very tightly controlled. And the reason we want to do that is because uncontrolled diabetes puts them at risk for those major complications. So the eye damage, the kidney damage, the nerve damage, the increased cardiovascular risk for heart attack and stroke. So keeping that under control is pretty important. First priority treatment for DKA, we kind of already addressed that, which with the HHNKS, hydration, IV fluids, IV insulin drip. If a patient is pre-diabetic, what's the best way to decrease their chances of getting diabetes? This is a great question because ideally we want to keep them from getting to the point that they're diabetic. When we talk about pre-diabetes, we're generally talking about pre-type 2 diabetes. So the biggest risk factor for type 2 diabetes is going to be obesity. So when we think about what we can do to help these patients decrease their chances of developing full-blown diabetes, it's really going to be about lifestyle modification. It's going to be about, you know, losing weight, trying to get down to a more ideal weight, maybe talking to them about their diet, reducing, you know, their total number of carbs per day. And in doing that, that should also help with the weight loss. The idea is for us to, you know, kind of manage things with diet and exercise lifestyle modifications. And hopefully that will get them to the point that they don't actually develop diabetes. Depending on how close they are, it's not uncommon for them to actually be started on metformin during that pre-diabetes phase, with the goal of, as we do the lifestyle changes and they lose weight, maybe being able to come off of that. All right, can you clarify the important side effects and nursing interventions for the type 2 diabetes meds? Yes. So when you think about your type 2 diabetes meds, the big things that you want to be able to know and to be able to tell your patients, it's just a basic concept of how they work. Because again, it's not uncommon for these patients to be on multiple oral or injectable anti-diabetic meds. So they need to know how they work. The other thing that really comes into play with this is anytime you're taking something that's going to affect glucose metabolism, they're going to be at potential risk for hypoglycemia. Now, if they're only on metformin, because of how metformin works, that risk is much lower. But if you're on anything that's going to stimulate the pancreas to produce more insulin, or for the insulin to be used more effectively, you have that risk of hypoglycemia. So knowing the signs and symptoms of hypoglycemia would be really important. You would want to teach that to your patient. The other things that are important is most of these medications, at least initially when they start them, are going to cause some GI upset. Might get a little bit of nausea, upset stomach. A lot of them can cause loose stools, especially when they're first starting. Now their body will adjust to that, but it might take a week or two. It might take a little longer than that, depending on what medication it is, but they will adjust to it. But they need to know to expect that. That's also the reason, particularly for metformin, that they will gradually increase their dose. Typically when they're starting somebody on metformin, and I tend to come back to that one because that's the most common oral anti-diabetic med that's used. It's also the first line treatment. So if we're going to put them on a medication, that's the first thing we're going to start with. But metformin definitely has those side effects. So they typically start with 500 milligrams once a day, and then they'll do that for a couple days. Then they'll bump them up to 500 milligrams twice a day. Then they'll get them up to 1,000 in the morning, 500 in the afternoon, evening, and then eventually up to 1,000 and 1,000. That's really the max dose of metformin that we'll see used. So gradually increasing that dosage, but teaching your patient to expect that. Other things that are important, we did talk about in depth about metformin. The sulfonylureas, really watching the alcohol because they can have that reaction. Basically, it's the GI one. The other class, and I can't think of what it is off the top of my head, but the ones that help increase glucose excretion through the urine. For those in particular, you would want to teach your patient that they're going to be at higher risk for UTI. So they would want to know the signs and symptoms of UTI. They would also want to take appropriate preventative action. So making sure they're staying well hydrated. Maybe incorporating some of that cranberry juice, trying to acidify the urine a little bit. And certainly being aware that that's a possibility, that they're watching for those signs and symptoms and reporting them if they occur. That's really the big pieces. Yeah, okay. All right, so moving on down to the next one. We have, hold on. My little chat window here is being goofy. Just give me a minute here. Okay, for gastric hemorrhage, why is putting the patient in a supine position with the elevated legs an effective priority intervention for the patient? So when you have somebody who has a gastric hemorrhage, that is going to drop their blood pressure because they have a really large amount of blood essentially leaving the circulating volume, and it's going out either into the abdomen, maybe you had a hemorrhage there, or maybe they've had a GI bleed and it's come out the top or come out the bottom. But either way, whatever has happened, you've lost a large amount of fluid. So the blood pressure is going to drop rapidly. So by putting them in a supine position and elevating their legs, that will help stabilize their blood pressure and really kind of focus on getting the blood flow, the blood circulation to the vital organs. Now, the one thing you want to really watch about this, though, when you put them supine, you always worry about airway. So it's very important for you to monitor your patient because depending on the amount of volume that they lost, that might alter their level of consciousness, their orientation, their ability to respond. So if you have somebody who is not completely conscious, not completely alert, we worry about them maintaining their airway. Okay, so you have to very closely monitor these patients, but the reason we would put them supine and elevate the legs, it's all about preserving circulation and really perfusing those vital organs until we can take the next step. Let's get the IVs and then let's start putting IV fluid in them to support that circulating volume. And then of course, for a situation like this, it's a gastric hemorrhage, you know, deciding what the course of action is. You know, typically they're going to do an emergency endoscopy, figure out where the bleed is. Sometimes if it's a small bleed, they can actually address that during the endoscopy. They can do cauterization, maybe even a balloon in there. that sort of thing. If it's a massive problem, if it's a massive perforation, this patient's going to require OR intervention because they're going to have to surgically address, what the problem is. Okay, in HHNKS, as you stated earlier, there's no ketone production. So how does the glucose level get so high? So there is some glucose getting into the cells, but it's not enough. So the cells are still functioning at a very, very low level, but they're still sending signals to the brain like, hey, I'm starving here, I'm starving. So what the brain then does is it tells the liver, hey, these cells are starving. You need to start breaking down some of that glycogen to provide that glucose source. And that's what the liver does. The problem is I'm getting more and more glucose in plasma into that circulation, but there's not enough insulin to be able to take it into the cells. So it's kind of a vicious cycle. And that's actually why you see with HHNKS, a lot of times the sugars are even higher than what you would see in DKA. Okay, can you please go over the sick days again? Okay, so the whole sick day thing, and it applies really to type 1 and type 2 diabetics, but really it's the type 1s are going to be at much higher risk because of the DKA. So what happens when someone is sick? Anytime you're sick, whether it's something as simple as a cold, you have a UTI, anytime your body is under physical stress from an illness or even psychological stress, like you may be feeling right now for the exam, needs go up. Okay, so because your body is working at a heightened state, it needs more energy, it needs more ATP to do that. So to make ATP, you need oxygen, you need glucose. So your body, in an effort to meet that need from a glucose perspective, will tell the liver to start breaking down glycogen into glucose. So we have that constant source of glucose. Well, when this happens, if somebody is sick, okay, providing the higher amount of glucose, even though I'm not necessarily eating and taking in food for glucose, I'm getting that from the glycogen, but there's not enough insulin to take that glucose into the cells. And this is particularly true in diabetics because, again, your type 1 diabetics, there is no insulin production at all in the beta cells. Okay, so the body is making more of this glucose because it's trying to meet the body needs, but there's no insulin to take it in there. Okay, and when you're sick, you do need more energy. So it's not uncommon for patients that are sick to actually have higher requirements for the insulin. Now, that doesn't mean we want the type 1 diabetic to be adjusting their insulin. They're typically told to continue testing their blood sugar at least every 3 to 4 hours and take their usual insulin dose. If they can't eat, that's okay, but we do want them to keep drinking fluids because we don't want them to get dehydrated. So with the fluids, they can have water, but we also want to have fluids that have some sort of a carb source in there. Not a huge amount of carb source, but a regular soda would be a little excessive, but things like G2, the Gatorade 2 are as important because it has glucose in there, but it also has electrolytes in there as well. So we want to maintain that hydration. So for sick day rules, you definitely want to make sure that they're drinking fluids, at least a little bit every hour, every 2 hours. They want to get some fluids in them. They should be checking their blood sugar every 3 to 4 hours. Type 1 diabetics should be checking for ketones. They should be checking their urine for ketones, usually every 3 to 4 hours. Because again, your type 1 diabetics, if they're spilling ketones, okay, they definitely are not having enough insulin to take that glucose into the cells. So the whole idea with this is to really identify, ideally preventing the problem, but really if there is an issue developing, identifying it early and treating it early before it turns into a full-blown DKA where they come in unconscious and in a severe metabolic acidosis. Okay, let me see here. I thought that the breakdown of glycogen, are you referring to glycogen maybe, included the breakdown of cells which creates ketones, or does it happen at a lower rate so that the body can clear them? Okay, so very good. I think what you're asking is the breakdown of glycogen. When glycogen breaks down into glucose, there's some byproducts, but it's not going to be enough that would raise somebody's ketones. When we talk about true ketones, okay, that actually comes from fat breakdown. Okay, so when the cells start breaking down fat to make ATP, that's where you get the ketone byproducts. And as those accumulate in the body, that's where you get a ton of ketones in the circulating volume. They pass through the kidneys, and the kidneys excrete them through the urine. Okay, but those ketones, they're an acid. They create an acidosis, and that's why DKA is going to result in a metabolic acidosis. Okay, for a hypoglycemic event, you'll check their blood glucose first, and then what? 4 ounces of, okay, so very good. So I'm assuming from your question here that they are conscious. Okay, so I'm going to check their blood glucose level. If they are less than 70, I'm going to start treating that patient with 15 grams of carbs. Okay, so it's 15 grams of carbs, whatever you can get into them. Now remember, they have to be conscious and able to swallow to safely take something PO. So when I look at that, 4 ounces of juice, 6 ounces of soda, glucose tablets, candies, they're all, as long as I have enough that's going to provide 15 grams, that's what I want. Now, of those options there, you want something that's going to be absorbed fairly quickly. So something that's already in a liquid form, there's nothing really to break down there, maybe a little bit, but it's going to get absorbed really quickly. Even the glucose tablets, ideally you want them to chew them up and take them down with some liquid. Okay, because again, if it's chewed up, it's going to be already broken down a little bit, easier to get absorbed. You're basically going to go with what you have. I would probably go with the 4 ounces of juice. That's typically what we will use. But the key piece is going to be that it's the equivalent of 15 grams of carbs. Candies, if that's all I have, that's great. But again, if it's a hard candy, it's going to take a little bit to dissolve. If I stick it under my tongue, it'll start to dissolve and it'll get absorbed sublingually. That'll help it be absorbed a little bit faster than orally. But again, the key is the 15 grams of carbs. And then you're going to wait 15 minutes and test them again and see what their blood glucose level is. If they are still below 70, you're going to treat them with another 15 grams of carbs. And you keep following that process. Once they get above 70, if it's going to be more than an hour till their next meal, you want to make sure you give them some carbs with some protein. Okay, this kind of goes back to the question we had earlier about the delaying the absorption of carbs. Okay, if I'm only treating hypoglycemia with carbs, which is what I want to do initially because I need to get their blood sugar up. But okay, I treat them with carbs, I get them up, and it's going to come right back down. The idea with adding a protein in there, particularly if their next meal is, you know, an hour or more away, is I'm going to raise their blood sugar. I want to get it up to the point that they're safe. It's not too low that it's going to cause damage to the cells. But then I want to keep it nice and steady. I don't want it up and come right back down. Okay. Okay. If you are out in public and someone is unconscious and you believe hypoglycemia, how will you treat them? Well, it depends. Okay. In the situation I described in the capture, I didn't have glucagon that I could give IM. I obviously didn't have IV equipment that I could start an IV on her and push D50 or anything like that. So if you're a lay person and you're out there, you use what you got. When EMS responds, they're going to check blood sugar, and typically they're going to treat with IM glucagon. And the reason they're going to do that is they can prepare and give that much quicker than it would take to put the IV in and then push the D50, the dextrose. Now, in a hospital setting, inpatient, most of your patients have IVs. So we're typically going to be using, if they are unconscious or they're conscious and they can't swallow and we need to treat hypoglycemia, we're going to go ahead and actually use the D50 because we already have IV access. So I guess where I would tell you to go with that in a question on the exam or on NCLEX would be to read your question carefully. What are the circumstances in that situation? What is the setting? Who is your patient? If they're an inpatient, it is safe to assume that they have IV access. Unless you're in the VSIM and the patient you can see has no IV, and then you have to start the IV. But generally your inpatients are going to have IV access unless they just literally have been brought in and they're in the ER. Okay, let's see. Are you able to maintain, are you able to explain when you would give promethazine versus ondansetron? Sure. So they are both antiemetics and they are both used as antiemetics. I will tell you it is much more common now to use ondansetron, Zofran, because it is a much more effective antiemetic. It works really well. The one situation where I would not give ondansetron would be to a patient who has a history of a cardiac dysrhythmia, specifically prolonged QT syndrome. I am so sorry. Hold on, let me turn that off. Mrs. Harbaugh was trying to call me. I'll have to call her later. But anyway, so the ondansetron, I would go with that as long as they don't have, again, that pre-existing condition, that prolonged QT interval. Because what will happen is the ondansetron as a side effect is going to lengthen that QT interval even more. And that would put your patient at risk for some potentially life-threatening dysrhythmias. So in that case, I would use promethazine. The reason we don't use promethazine as much anymore is because it does have some very sedating side effects. It really causes your patient to become very sleepy. A lot of times we give antiemetics in conjunction with narcotic pain medications. So we already have the respiratory depression piece from the opioid, and now we're adding in the promethazine. So you're having those two things together. And they really create a synergistic effect. And we worry about respiratory depression. And I've seen it happen. We've had patients come back from the OR. They've come back from PACU. They've gotten some pain medication in PACU. They've gotten a dose of promethazine, and it all hits at once. They're up on the floor and they're breathing, 6 times a minute, and we're calling a rapid response. And it's because of that sedation. So both of those medications are effective as antiemetics. Again, ondansetron, Zofran is probably used much more frequently, but do keep in mind that one caveat where you want to be very careful. Those patients with prolonged QT would not be good candidates for ondansetron. And just as a side note, there's a lot of medications that actually cause a prolonged QT interval. One that's in the news right now, azithromycin, Zithromax, that they're talking as part of treatment for COVID-19. That actually is a medication where you would not want to give that to somebody with a prolonged QT interval, again, because of the risk of the cardiac dysrhythmia. One of the questions on PrepU asked, what was the main way to test for colon cancer? Thought it was colonoscopy with a biopsy. New way was ultrasonography. Okay, I am not familiar with that particular test. Certainly ultrasonography would be used to evaluate if there's like liver metastasis or something like that. But generally that's not going to be diagnostic for colon cancer. And the other thing, when we talk about diagnosing cancer, the biopsy is your gold standard. Even if I had an ultrasound, it might show me or show the provider some suspicious areas that might lead me to believe there could potentially be a cancer there, but ultimately they are going to need that biopsy to determine what do those cells look like under the microscope, and is this a cancer, is this not? Still, your screening test for colorectal cancer, we're going to do the stool for occult blood, but then the screening is after age 50 in a normal healthy person. After age 50, they should be having a colonoscopy at least every 10 years. If they find something on the colonoscopy, they would want to repeat that, in a shorter time frame. If they found something or they found some polyps and they want to remove those polyps, then it wouldn't be another 10 years. It might be 5 years. It could be every year. In somebody with a strong family history or strong risk factors for colorectal cancer, it could be as frequent as every few months for a colonoscopy. How would you decipher hypoglycemia or overdose if out? I'm assuming you mean like a narcotic overdose. So with that, and well, in today's society, it might be difficult to decipher those. So, but here's the thing. Hypoglycemia, if it's EMS, I can, check the blood sugar. Even if I'm not EMS and I treat it as hypoglycemia, I'm not going to cause any harm to the patient. If it's an overdose and you treat it with Narcan, hopefully they'll come out of it. Even if it's not an overdose and you treat it with Narcan, it's really not going to cause the patient harm. But both of those situations are potentially life-threatening. And of course, that's treating potential underlying causes. When you find somebody who's down and unconscious, you also want to support their airway. You would want to support their breathing. If they're only breathing 6 times a minute, they need some rescue breathing, rescue breaths. As long as their heart is still beating, they don't require CPR, but we still might need to provide some respiratory support. Can you go over the HIDA scan and when you would want to use that? Sure. So the HIDA scan is a nuclear med test, and that is used really to evaluate gallbladder problems. Usually your first line, if we're thinking that it's a gallbladder problem, they're going to start with an ultrasound of the liver, ultrasound of the gallbladder area. And typically, in most cases of gallbladder issues, you can visualize stones with the ultrasound. I mean, it's pretty obvious what the problem is. In cases where you cannot visualize stones, so there's no stones there, but they're still having these symptoms and it's still related to, they look at the onset of the symptoms and how it relates to the time where they ate, and they're still thinking it's a gallbladder, they may elect to do a HIDA scan. So the HIDA scan is an elective test. It's usually not done as an emergent test, but what it involves is injection of a radioactive isotope, and that kind of circulates through. And then they will infuse a medication, we call it CCK. And basically what it does, it makes the gallbladder think that you just ate, and it causes the gallbladder to contract. The radioactive isotope that we gave previously, as they're taking pictures, that acts as a contrast so you can see how well the gallbladder is emptying. So that's helpful to determine, is this a spastic gallbladder? Is there possibly some sort of gallbladder obstruction, either in the actual gallbladder itself or maybe in the bile duct? Basically looking at the emptying of the bile from the gallbladder and seeing if there's an issue there. But again, that's not usually a first line test. They're typically going to do the ultrasound first to see if we can visualize gallstones. Just to clarify, in a patient who has renal impairment and you're to administer an acid, you would want to give a calcium-based over one with magnesium and aluminum. Yes, that is true. Now, it is going to depend on how severe of a renal impairment we're talking about. When we talk about kidney disease, and particularly chronic kidney disease or chronic renal disease, chronic kidney impairment, we look at the GFR, the glomerular filtration rate, and based on that, it will have them classified in stages. Are they stage 3A, chronic kidney disease, 3B, stage 4, stage 5? Stage 3, they would probably do okay with magnesium or aluminum, but it's just a good rule of thumb that they would tolerate calcium a little bit better. When you get into stage 4 and stage 5, we get concerned about them becoming magnesium or aluminum toxic, where the kidneys just simply cannot be able to excrete those substances. So then they build up in the blood and the patient can become toxic. So yes, definitely with the antacids, calcium-based are probably the most safe with that, but magnesium and aluminum, when you have a significant level of kidney impairment, those things are going to accumulate in the blood, in the body, because they're just not able to be excreted as easily. So, all right, well, that's all the questions that are on there for now. Anybody else have any other questions? If not, I have some pondering points and points of wisdom, pearls of wisdom, I guess I should call them, I don't know. Any questions? Okay, well, if you have questions, go ahead, type them in. I can always come back to that. So here's what I am going to tell you. I know that this change to online is just so different. It's not what any of us planned. It's not what any of us want. Okay, oh, wait, before I go there, let me come back. Will you have generic or trade names on the test for meds? It's going to primarily be generic. I've tried to go through and really remove the trade names, mainly because NCLEX doesn't have those on there. So generics, plan for generics. If I missed a brand name in there, if there's a brand name in there, it also has the generic. But I've been working through trying to pull the brand trade names out because you're not going to see those on NCLEX. So generic names. So back where I was going now. This is not what any of us anticipated. You know, I was hoping to be able to give this exam paper pencil. Eventually we were going to make the transition back to electronic, but it wasn't supposed to be with this exam, but it is what it is. I don't have control over it. You don't have control over it. But what you do have control over is how you prepare for it and how you take it. So here's what I'm going to tell you. This is rhetorical. I don't have any of your videos on right now, so you can shake your head yes, you can shake your head no. I don't need to know. But before you take this exam today, if you got up this morning and you have not taken a shower, you need to take a shower. You need to change your clothes. You need to make your hair all pretty. If you wear makeup, put your makeup on. I want you feeling good. Just like your patients who have been in the hospital for a while, maybe they're sick, maybe they're depressed, they just don't feel like their normal self, their routine is off. When they have that shower, when they do that personal care, they feel a lot better. It changes their day. And the same is true with you. So if you haven't done so, when we get off here, go take a shower, okay? Secondly, make sure you eat something. Get some nutrition in you, get some protein in you, okay? You need that ATP for your brain cells, okay? You need it. Use the techniques that we've practiced in class when we went over exam reviews and we looked at NCLEX questions, we looked at exam questions. Remember those keywords, identifying those keywords, thinking about what's going to kill my patient first. And I know I've talked to several of you. You need to brain dump that on your piece of paper. What will kill my patient first? Which item, which one of these options, if I don't do, is going to cause my patient the most harm? Okay. And which option addresses the cause of the problem? You know, you've gone over these exams before. So you know a lot of times when you answer something incorrectly, it's likely because you've misread something. So what is the question asking you? Okay, what is the question asking? The other thing, and you know if this applies to you, you know I'm talking to you directly, trust your gut. Trust your gut. You guys are so much smarter than you give yourselves credit for. You know so much more than you think you do. When you read the question and you think about it, okay, what's the question asking? And you read your options, what is your first gut instinct? That option is usually correct. You may not remember exactly what you read, exactly what you heard in a capture, or exactly what we talked about here, but something is drawing you to a particular response. And 9 times out of 10, it's right. Okay, so you need to trust your gut. Now, if you look at the question, you go back and you reread it, and you can say with 100% certainty, not 95, 100% certainty that, okay, I misread this question, I missed this keyword. With this keyword, it changes the answer to this. If you can say that with 100% confidence, then I'm okay if you change your answer. But if it's one of those, well, but if I think about it this way, it could be this, and this is what they do at work, and my Aunt Gladys is diabetic, and no, do not change that answer. Again, something drew you to that initial response. Trust your gut, trust your preparation, trust your studying, okay? You know yourself. You know when you looked at your exams and you're like, oh, I changed my answer, I changed my answer. For many of you, that changing of your answer, changing it to the incorrect one, probably cost you 4 to 6 points. Some of you it cost 10 to 12 points. That's significant. So trust your gut. If you think about where you are, where your nurse brain is compared to when you started Foundations last August, it's amazing. It is absolutely amazing. So trust in your knowledge, trust your gut, okay? Use your tools, use that blank piece of paper after you show it on the Respondus monitor, do your brain dump, write down your lab values, write down things that, you know, you were struggling with as you were studying to keep those concepts clarified, okay? But you can and you will do well on this exam. I have faith in you. I know you will do well. I know you will. What is this? I don't want to. Hold on. Let me read what you're saying here. Oh, like when you realize you read dyspepsia as dyspnea. Yep. Okay. So if you legitimately misread a question, I'm totally okay if you go back and change that. Will we see our exam grades after we submit it? No. And I went in and made sure because I screwed up the first time around and it was not supposed to release your original grade. And it did. It is what it is. It's water under the bridge. This time, no, it is not going to release your grade right away. Okay. It will not. It will not. And if for some reason it does, you better call me right away and tell me. Okay. But I have it on there. It will, it should, it will not. Okay. Now, that being said, the window to take the exam today is 12 to 5. That theoretically means it could be 6 o'clock because if somebody logs on right before 5 o'clock to have access to it, they may not finish until right before 6 o'clock. So what I will do later on this evening, once everybody is done, I will start looking at the exam statistics. Of course, I have to do all my item analysis and everything. So that will take a little bit of time. My goal is to get grades into the grade book sometime tomorrow because I don't want you twirling all weekend. You know, but so that's going to be my goal. Okay. Just to kind of give you a heads up. Okay, let's see here. Silly question. I got a cough watching our eye. No, if you cough to the side, that should be fine. What's going to happen, the way Respondus Monitor works is it watches you. It's kind of like Big Brother. It will flag things. So that would probably flag. All that means is it flags on my end and I go in and I look at your video and I see what's going on. I mean, if I can see your cough, you know, to the side, I can see what's going on there. You know, so all that does is flag in the system and it's just a prompt for the faculty member to go in and look at it. You know, so that's what I do. So you can make silly faces at me. I don't care. I'm not watching each of your videos the whole way. If it flags, I'm going to check it out. You know, but I would, you know, as much as possible, just like you would do in the regular classroom. I know some of you have kids at home. If somebody else could be watching them so you can kind of dedicate yourself to the exam and not have interruptions, I think you're going to do better. If you have somebody else that can just handle that for, you know, the hour or so that you're taking this exam, that would be ideal. But yeah, so if the system flags, I'm going to go look at the video and then, you know, I go from there, you know. Now, obviously, if I have somebody in the video that's like this and they're looking and they're this and they're, you know, I can, this isn't my first rodeo. I've you know, done this before, so, you know, we can find that. But I don't want you necessarily freaking out over the Respondus Monitor. Nobody sees that video except for me, and I don't specifically go in and look at everybody's video. I look at what the system, the AI flags for me to look at, okay? Now, if there's an issue with the flag, I mean, I am going to go look at it, but other than that, it's more to maintain the security of the exam. And usually students, when they know they're being watched, they're, you know, it really cuts down on any potential issues. So let me see here. Let's see. So, well, I don't know what that comment was about, but we'll just ignore that one. So we can start at any time between 12 and 5. It won't shut off on us at 5 if the exam is open already. That is correct. You can access the exam from 12 to 5. Okay. Once you're in there, just like you had with the Unit 1 and 2 exam, you'll have your own timer and that'll display on the screen, so it will keep going. Let's see here. In the PowerPoint about test taking, it says to scan your environment before. Do you want the whole room or just where we're sitting? I would like the whole room because there could theoretically be something, you know, behind the computer. So really, just like in the demo video in that YouTube tutorial, you do want to kind of scan the whole room, please. Let's see. Oh, I missed a question. Can you answer Tori's previous question? Do me a favor, Tori. I think it kind of went down. So if you could re-put the question in there, I will do that. Are there any bonus questions? No, not at this point, since we have no way to do collaborative testing. There's not. I want to kind of evaluate how this goes. Moving forward, we might end up putting some bonus questions on there. I'll be honest with you, I don't think you're going to need them. I really don't. I'm really feeling good about this exam. When I look at where you guys have come from that very first test, which was an awful, awful day for everyone, and how you guys did on the last exam, and the jump in scores, and you know how engaged you guys have been, even with having to go online and having this huge upheaval. Our Zoom session right now, there are 29 of you on this Zoom session. The other day when we were on there was 33 of you on that Zoom session. I've seen the work that you're doing. I've seen the prep you that you've been in. I really feel confident about this exam. I really feel that you guys are going to do really well. You know, and sometimes I have more faith than you do, but I really do. I know that you can do this. I know that you are prepared. Are you going to be a little anxious? Sure. Are you anxious with every test? Okay. Is it different because you're testing using the computer with the respondents monitor? Yeah. But you still think about the questions the same way. You still identify the keywords. You still trust your gut. Trust your gut. You still do the same things, and you can do this. I know you can do this. Let's see here. Yes, from my lips to God's ears, absolutely. I just want paper. Yeah, I know, but at some point, this was probably going to be your last paper exam anyway. So, you know, it is what it is. We don't have control over it, but you do have control on how you respond to taking the test this afternoon. Okay. All right. So any last minute questions? Can we hold our blank paper up to the screen to cover the answer options? Absolutely. Absolutely, you can do that. I encourage you to do that. I want you to use those test taking techniques that we talked about. Okay. I want you using those. I want you identifying those keywords. I think I said in the PowerPoint too, when I had set up the very first exam, that unit 1 and 2, I had clicked something in there that didn't let you right click and highlight. I did not click that this time. So you have lockdown browser. That's not going to let you be clicking outside of the browser, but I did leave where the right click was enabled. So that can also help you if you're trying to highlight a word. Let's see here. I feel like it's been hard to focus and study in a different environment. Totally. I can totally see that. Always use the library and never study effectively at home. Okay, so let's talk about that a little bit. At least for today, for the exam, as much as possible, if you can kind of get yourself into an environment where other people aren't going to be around you, that you can kind of focus for this hour. You know, moving forward, unfortunately, the library is closed. I've had some colleagues of mine who are working on master's classes and doctoral classes that sometimes go out in the car to study. They sometimes sit on the back porch to study away from other people. That can be really hard, you know, because it definitely is a change in your routine. Those of you that have kids, if they're running around all day, that can make it really difficult to study as well. So it might be a matter of adjusting, you know, your schedule a little bit. Maybe when the kids are sleeping, maybe I get up an hour earlier so I can study with that, or maybe I'm, you know, getting up a little bit later, staying up a little bit later. So trying to adjust that. You know, my hope is that, you know, this whole stay at home order gets over pretty quickly. But the reality of it is we're kind of at the mercy of the virus. And, you know, I don't have control over that. You don't have control over that. You might not be able to find a place or a chunk of time where you can study for 2 or 3 straight hours. You may really have to switch to, okay, I got some alone time, free time in the morning. Somebody else has the kids, or the kids are focused on this. This is what I'm going to do here, and really kind of target your study time and plan your study time with that. Okay, more questions. Do we need speakers for any part? No, you don't need any speakers for any part of this. Most of your computers are going to have a microphone, so the camera, the Respondus monitor picks up that, but you do not need any speakers for any portion of this test. I watched the tutorial and it says we need our student ID. No, you don't need to do that for this exam. That is perfectly fine. They were showing a generic tutorial, and they use Respondus monitoring for all sorts of programs across the country. So theoretically, the person proctoring it may have never seen that student before. That's more for your true online courses where I, as an instructor, may have never seen you in person. I don't know what, who so-and-so looks like, just to make sure the right person is taking the exam. It's not my friend Bob who's taking the exam for me. But since I know all of you, you are in my class, I know who all of you are, there's really no need for you to show your student ID. I know who you are. So, all right, I think that's it. I don't have any music queued up, but if I had music queued up, I'd like play Eye of the Tiger, maybe, or like Rock You Like a Hurricane by the Scorpions or something, because you're gonna rock this test, okay? Now, as Larry the Cable Guy says, get her done. And I'll see you later.